Ladies and gentlemen, dear colleagues, good evening. It is a pleasure and honor for me to be here today, and I would like to thank the scientific committee of the Turkish Academy of Aesthetic Dentistry, and in particular, Mrs. President, my friend, Dr. Özkut, Dr. Çomelekoglu, and Dr. Gurel for such a prestigious invitation. Moreover, let me give you the greetings of the University Federico II of Napoli in Italy, where I deal with prosthodontics and digital dentistry. We are living difficult and strange times, but fortunately, digital networking is a powerful tool to keep in touch and share knowledge, and value and the success of the present EDAD online meeting is the proof of this. I've been to your beautiful country several times. I have many friends in Turkey, and although I miss your warm welcoming this evening, I feel just like being there with you all. I was requested to give an update about the current state of luting and bonding to tooth structures and dental ceramics, and I found this topic really challenging, as in the last decade, improvements in dental materials have dramatically changed the clinical approach to cementation. This hot topic would request much more time than 45 minutes, so I'll try to focus your attention on some hints about the most updated clinical and scientific evidences. Just a very brief introduction about myself. I come from Napoli. It's a very beautiful city located in southern Italy, lying next to the sea and in front of our respectful volcano, the Vesuvio. Napoli is well known all over the world as the homeland of pizza, but also for one of the oldest universities in the world, the University Federico II, where I play most of my clinical and research activities. Anyhow, Anyhow, I have to introduce you to Siena as well, which is a small medieval town situated in the heart of Tuscany, famous worldwide for the Palio, an historical horse racing dating back to the 13th century, and for another ancient and prestigious university where I currently lecture at the International Master Program in Aesthetic and Digital Dentistry. And finally, let me introduce you to my clinical team and Zerodonto, a dental community I've founded a few years ago with my colleagues. Our pages are present in all the social media, just like Facebook and Instagram, and receive approximately 3 million visits per month. All the pages are completely free and represent a powerful network to share clinical and research experiences with colleagues from all over the world. Well, after this due introduction, let's move to the topic of today. And when the topic is cementation, the first question usually asked is how to make it. But according to me, the first and most important consideration should be where to cement, carefully selecting the luting techniques, since the substrates we have to work with are very different for both biological and material properties, being enamel, dentin, and cementum, or composite metal or ceramics, or even a mix of them all. And the proper comprehension of how to manage these substrates and condition the surfaces is the first undoubtable step toward the clinical success. Moreover, the proper selection of luting techniques has to consider what we have to cement, and consequently, how we have to treat the surfaces of dental tissues and materials before the cementation. For example, metal ceramics and all ceramics restorations present completely different optical properties, but zirconia is a ceramic oxide of metal, and this significantly influences the approach to its cementation, particularly if adhesive. Conversely, the technique changes with glassy materials, just like feldspathic or luxite-reinforced ceramics. Very appealing from an aesthetic point of view, but less tough, so needing an active cementation to be strengthened and create an adhesive monoblock. Or just like silicates and disilicates, whose wrong management on the basis of presumed fashions of the moment could cause clinical failures, particularly in posterior areas. And furthermore, nowadays, it seems that cementation is almost a synonym of adhesion. But although adhesive procedures can be useful in the presence of unfavorable preparation geometries, a conventional cementation approach still represents the first choice when preparations are retentive and the characteristics of restorative materials allow for such approach. Of course, the classical paradigms of precision and biological respect have always to guide clinicians and lead any treatment plan, profiting by the best properties of innovative restorative materials and updated techniques, as we have reported in these recent publications. And in this slide, you can see the overview of my today's speech. We will go through the characteristics of dental substrates and luting agents, the surface treatments of dental ceramics, till the clinical procedures that should guide practitioners in the selection of the most proper cementation technique. And let's start from the conditioning and biomodification of dental tissues. According to the principles of minimal intervention dentistry, the preservation of the maximum amount of sound tooth structures is always mandatory, and the knowledge of the intrinsic characteristics of dental tissues and the understanding of their adhesive properties and potential is paramount to select properly the most appropriate cementation procedure. And considering that the range of clinical acceptability and effectiveness for adhesion is about 17 to 19 megapascal, it is worth noticing how older generation adhesives were much more effective on enamel. The time passed, the clinical procedures have been improved, but most practitioners still believe in this conviction. But today, the most recent adhesive systems are really performing even on dentin, although the less satisfactory clinical results have to be referred to the more difficult management of adhesion on dentin and to the more complex control of the intrinsic moisture. We all know that the dental market is crowded with different adhesive systems with a strong trend towards simplification. From the traditional three-step chain rings to bicomponent prime and bond or etch and prime agents, till the so-called all-in-one systems in which the etchant, the primer, and the bonding are diluted in the same solution and have to act more or less simultaneously. It is worth remembering that the hydrophilicity of dental adhesives is related to their acidity, at least during the setting, and that the three-step adhesives are the only to be used on dry substrates, whereas the simplified systems have to be applied onto wet tissues, particularly onto dentin. But how wet? To date, no research stated clinically objective criteria to understand how shiny or how glossy a surface has to be prior to adhesive rubbing. So, simplified systems are actually easier to be used, but contrary to marketing advertisement, are operator sensitive at the same time indeed. And the three-step systems are more stable as regards marginal microleakage and staining. So they should be preferred on enamel and anterior teeth to prevent marginal pigmentation over time. And recently, in 2011, a new class of dental adhesives was introduced to the market, the universal or multimode agents, that were designed as all-in-one systems, but with the innovation to be used with etch and rinse, self-etch, or selective enamel etching techniques, so being very versatile and overcoming the drawbacks of previous self-etch adhesives, just like inferior bond durability and marginal discoloration. As a consequence, practitioners can decide on a specific adhesive protocol according to the specific clinical conditions, adopting the simplest solution of each technique. There are several universal adhesives available on the market, but the most innovative and captivating, just like the G-Previa Bond by GC, are provided with different functional monomers and dual cure activators to be used with all dental substrates and restorative materials. If we look at the most recent literature regarding the universal multimode adhesives, it is clear that their bond effectiveness is satisfactory for clinical use, that the use of the selective enamel etching technique can be useful to increase long-term durability of the adhesive complex, that the bond strength of multimode adhesives is dependent on the brand, and that it can be increased with prolonged air blowing up to 30 seconds to make the bonding layer very thin and uniform, and that universal adhesives have shown promising results, but their clinical behavior has to be better investigated and understood in the long term. So briefly, we can classify to date available adhesive strategies in three groups. The etch and rings, that is related to the use of the classical three-step adhesives. The self-etch, that is characterized by the use of different two or one-step systems. And the universal adhesives that need only one solution and can be used as self-etch agents or can be anticipated by the application of an etchant in the etch and rings mode, selecting the total etch or selective enamel etching techniques according to the specific clinical needs of the case. But independently from the adhesive system, the creation of a stable hybrid layer is crucial for the effectiveness and durability of bonding. To date, the achievement of clean adhesion, as in the laboratory setting, is very difficult to be obtained clinically, but the use of proper procedures and the correct selection of the bonding techniques offer highly performant alternatives to prevent the degradation of the adhesive interface. Now, let's move to the second chapter of this speech, going through the most important features of luting agents in a clinical perspective. It is well known that cementation has to guarantee retention of prosthesis, marginal seal, and longevity of restorations. In other words, the cementation baseline represents the first step towards restorative durability and clinical success over time. The properties of an ideal luting agent are definitely clear. Absence of postoperative sensitivity, effective seal, easy handling, no aesthetic interferences, minimal thickness, and radiopacity. Probably strong bonds should be considered a useful option, but not a basic prerequisite, at least in the presence of retentive geometries and primary retention. And schematically, it is possible to classify dental cements and conventional water-based luting agents, just like zinc-containing polycarboxylate and glass ionomer cements. The more recent monomer-based cements, just like the total etching and the self-adhesive luting agents, noticing that all recent cements can be self-curing, light cure, and dual cured. And in between these two main groups, we have the hybrid cements, a class with intermediate characteristics, such as resin-modified glass ionomer cements. Moreover, as regards the bond strength, it is also possible to classify these luting agents in low adhesion, namely the traditional water-based cements, medium adhesion, including the resin-modified glass ionomer cements and the self-adhesive resin cements, and high adhesion luting agents, that's to say the conventional total etching resin cements. As you can see in this graph, all luting agents present adhesive properties towards enamel and dentin, ranging between 1 to 2 megapascal for zinc phosphate to 25 megapascal for conventional resin cements. The bond strength is usually better in the presence of enamel, with the only exception of the three-step resin cements that show similar values onto bond substrates and slightly better onto dentin. As a consequence, on the basis of the different characteristics of the mechanical interlocking and active adhesion to dental substrates and restorative materials, it is possible to state that differently from the common convictions, all cements are somehow adhesive, according to their intrinsic chemical properties. And as anticipated, the best bond strength values are offered by resin cements, but with great differences between the conventional three-step and the simplified self-adhesive cements. The former reach 60 megapascal, standing out mere bond strength, while the latter show 15 megapascal, mainly guaranteeing a good marginal seal. And self-adhesive cements are claimed as very easy handling materials due to simplified adhesive approach. Nonetheless, their long-term behavior has to be completely understood yet. And as reported in this review, contrary to common sense, self-adhesive cements present better performances onto dentin than to on enamel, because of the necessity of a certain amount of substrate moisture. Although their effectiveness is satisfactory for clinical use, the absolute values of bond strength are inferior, and the risk of marginal discoloration is higher than traditional total etch resin cements. This recent review of the literature pointed out that self-adhesive cements are gaining popularity because of their ease of use. The clinical performances, at least in the short term, are comparable to those of traditional cements, but further clinical studies are necessary to draw definitive conclusions regarding their long-term clinical performance. Of course, to achieve the best adhesion, we have to manage clean surfaces. Particular, the remnants of provisional luting agents may interfere with the final cementation, particularly if you go for adhesive protocols. And they have to be thoroughly removed, and alumina particle abrasion proved to be the most effective procedure. Moreover, as regards the antibacterial activity, the role of chlorhexidine is controversial, and it can lower the final bond strength. So glutaraldate cross-linkers, just like cleansing agents, desensitizers, and adhesion enhancers, should today be preferred to prime the dentinal substrate. And substrate surfaces have to be cleaned before the final cementation, and not only blood and saliva should be considered contaminants, but also cynical disclosing materials and any other particle debris. Water and acetone are not useful to remove the remnants, whereas the application of cleaning passes and phosphoric acid proved to be effective in removing all the contaminating debris. And after cementation, it is necessary to identify possible cement excess, and radiopacity is a very useful parameter. Obviously, the metal-containing luting agents are more radiopaque, whereas aesthetic cements are more radiolucent. But nowadays, most manufacturers add radiopaque components in translucent cements as well, to better visualize the restorative margins of aesthetic restorations, just like this radiograph showing a couple of laminate veneers. It is worth noticing that the cement radiopacity can decrease with aging, and that the cement film generally used in the laboratory setting and in the manufacturer's quality controls is 5 to 10 times thicker than it is used clinically. As a consequence, there could be a radiopacity mismatch between technical specifications and the real clinical performance of the cements. Of course, similar to two tissues, ceramic substrates have to be conditioned with surface treatments as well, in order to improve the clinical effectiveness and longevity of cementation. And when we talk about ceramic conditioning, we immediately refer to the well-known procedure of ceramic etching, mainly using aggressive agents just like hydrofluoric acid. However, the acid etching technique can be used only with glass materials, just like feldspathic and silicate-based ceramics, but not with the polycrystalline cores, just like alumina and zirconia, since the latter contain less than 5% in weight of silica particles, the only component that can be primed by acids. Independently from the material, and just like dental tissues, the overetching should always be avoided, since it could determine a degradation of the ceramic interface, causing a significant worsening of the adhesive properties over time. And particularly due to its aggressive nature, hydrofluoric acid could weaken glass ceramics and negatively influence the bonding performance on the basis of both concentration and application time. Several studies prove that concentrations ranging between 9 to 10% are too strong. They may decrease the bond strength and weaken particularly lithium disilicate, increasing the risk of onset and propagation of microcracks within the material. As you know, hydrofluoric acid is available in different concentrations, and laboratory studies showed clearly that 5% is enough to partially remove the ceramic glass symmetrics with no weakening and creating an effective superficial etching pattern. Consequently, the lowest effective concentration should always be used. And according to manufacturers' instructions, recommended etching times change on the basis of the glassy content. In other words, the higher the silica percentage, the more aggressive the etching protocol. As a consequence, we should etch purely glassy materials as feldspathic and lucite reinforced ceramics for 60 seconds, silica-based substrates for 20 seconds, and hybrid ceramics, just like the newer polymer infiltrated ceramic networks, for 60 seconds as well. However, in order to preserve the ceramic microstructure, strong etching protocols should be always avoided, particularly in the presence of very thin restorations, just like laminate veneers and tabletops. So briefly, we can summarize the ceramic conditioning in 4 steps. Hydrofluoric acid etching for 20 to 60 seconds according to the silica content of the material. Surface cleaning by means of surfactants or dedicated cleaning solutions. Surface ultrasonic degreasing using 96% of ethanol. And finally, the application of coupling agents such as MDP containing primers or silanes. However, this approach cannot be used with polycrystalline ceramics, just like zirconia and alumina, since they are acid resistant and insensitive to the etching and silane bonding technique. As a consequence, they cannot take, to date, full advantage from the conventional adhesive procedures, although the scenario is changing over time. A few years ago, we published this SEM study about ceramic conditioning using a very aggressive etching protocol, precisely 40% of hydrofluoric acid etching for 2 minutes. And we showed significant surface modifications onto feldspathic materials, but not onto zirconia, concluding that to date, the latter cannot be considered a first choice material for purely adhesive restorations, just like veneers and onlays. Thus, due to its metallic nature, zirconia can be cemented using traditional water-based luting agents, such as glass ionomer cements and resin-modified glass ionomer hybrid materials. However, resin cements can be useful in case of poorly retentive preparations and short clinical crowns, or to seal minor surface defects due to CAD/CAM fabrication, particularly in case of art machining of fully sintered zirconia blanks. A strong resin ceramic bond relies on both micromechanical interlocking and chemical bonding, and insufficient surface modification could affect negatively the retention of ceramics. Several surface treatments for zirconia were described in the literature, as you can see in the slide, from abrasion to tribochemical techniques, from grinding to plasma spraying, and from metal primers to laser treatment. But data are not conclusive yet. There is no universal surface conditioning technique, and the indications still remain controversial, recommending to evaluate carefully the cement to be used. To date, as regards pure polycrystalline cores, evidence-based data state that adhesion onto zirconia is still discussed and less reliable than onto glass ceramics. No consensus has been found yet about the ideal surface conditioning, but most authors agree about the combination of mechanical and chemical treatments, and that further laboratory and clinical studies are necessary to draw clinical recommendations about long-term adhesion onto zirconia. So to date, I'm used to say that adhesion onto zirconia relies on the 3P. It is possible, it is not predictable, but it is promising. Consequently, right now, caution has to be paid for those restorations that do not have primary retention as veneers and onlays. However, if the opacity does not make zirconia necessary for aesthetic laminate veneers, it would be advisable to make very thin adhesive posterior restorations, just like tabletops and monolithic configuration, so as to reduce the abrasiveness against the opposite dentition. Well, we have talked about conditioning of dental substrates and pretreatment of ceramics. Let's see now how to avoid surface contamination during the clinical procedures of cementation by means of operative field isolation techniques. It is well known that the achievement of good adhesion relies on the management of clean surfaces And in this perspective, the isolation by means of the rubber dam is crucial to prevent any contact with blood, saliva, and other contaminating agents. The careful control of moisture is an indispensable prerequisite to obtain the best bone strength values that can be reduced up to the half in the presence of surface contaminants. And this approach is mandatory, particularly in the presence of adhesive restorations without primary retention, just like veneers and onlays. And I would like to show you a clinical case introducing you Ricardo, a young patient who was not satisfied with the shape and diastema of his upper front teeth, very evident while smiling. He was dissatisfied with the square geometry of his incisors. Some composite had been previously used by other colleagues to modify somehow the shape of the laterals, but the overall aesthetic result was not satisfactory at all. On the basis of the aesthetic analysis showing an evident alteration of both inter and intradental proportions, my prosthetic project contemplated the fabrication of 4 lithium disilicate veneers. The gingival margins of the central incisors were too coronal, and since passive eruption is a common evidence in these cases, I performed a conservative crown lengthening by means of a simple gingivectomy of the central incisors, guided by the contour of the mocap. After tissue healing, I went for a mocap guided preparation of the maxillary incisors, and I made a digital impression. And on the basis of the biomechanical needs of the case, I asked for 4 Lisi press laminate veneers by GC, extolling the translucency and opalations of the glass symmetrics and profiting by the mechanical resistance of lithium disilicate at the same time. And after color check, I prepared the ceramic surface for adhesion as I've previously mentioned. As I was onto front maxillary teeth and the veneers were made up of a glass ceramics, my choice was a total etch approach with a universal adhesive resin cement, namely the G-Assembling Force by GC, a very versatile product in my opinion. Consequently, the use of the rubber dam to isolate the operative field and prevent surface contamination was mandatory, as it was a standard and very easy clinical situation. The aesthetic and biologic integration of the veneers was definitely satisfactory, with the natural tooth-like appearance of the restorations and complete healing of the gingival tissues. Nonetheless, although aesthetics is important, very important for patients, and the primary goal for most dentists, I'm a prosthodontist, and for me reliability means a proper function and correct occlusion. So the real clinical success is represented by these images showing the precise reproduction of the occlusal scheme designed in the articulator. Wide areas for the sliding movements that represent a reliable insurance for the structural integrity of the ceramics over time. And besides the optimal mechanical properties, however, pressed lithium disilicate is characterized by excellent translucency, as we have highlighted in this recent retrospective clinical study on more than 800 restorations with different clinical configurations. Moreover, its biocompatibility was evidenced by the optimal healthy condition of these gingivas under the stereo microscope, confirming that the cementation was performed correctly. And this is Ricardo before and after the treatment, finally satisfied to show his smile with correct dental proportions, healthy soft tissues, and good biomimetics. And the same approach can be used with full coverage lithium disilicate crown as well. And as in this re-entry case on the previous metal ceramic restoration, in which I chose a Lisi press single crown layered buccally, but left monolithic on the palatal functional surface, so as to avoid any risk of chipping. Since I had primary retention, I chose a simplified adhesive protocol using again the G-Assembling Force, but this time with a self-etch approach. Although complete isolation is not mandatory when you go for simplified cementation of full coverage crowns, the use of the rubber dam makes cementation faster and easier. However, when you use self-adhesive cements, remember to protect carefully the adjacent teeth with Teflon tapes. Otherwise, you can waste a lot of time in removing cement excess from the interdental spaces by means of blades or finishing burrs. And here you can appreciate the pre and post-op comparison with no gingival intervention, as the patient had a very low lip line and was not interested in any kind of level. So isolation makes our adhesive life much easier, but more than half dentists declare not to use the rubber dam. And these are recent data obtained from questionnaires collected in the United States, the leader of the global dental market. It is worth noticing, however, that more than 70% of American practitioners do not use purely adhesive resin-luting agents, but prefer glass ionomer and hybrid cements, choosing conventional and simplified cementation techniques. And I'm quite sure that in Europe, the trend is very, very similar. So we have to point out that clinically different cementation techniques exist according to the clinical needs of the case and to the type of the luting agent. We can distinguish in low micromechanical adhesion, mainly based on surface interlocking and using traditional water-based cements, medium chemical adhesion by means of simplified self-adhesive and resin-modified glass ionomer cements, and purely high adhesion using the adhesive chemical bonding offered by conventional total etch resin cements. Of course, different luting agents necessitate different isolation approaches. No dam is strictly needed for water-based materials. Moisture control by means of different isolation aids can be achieved for simplified adhesive systems, while the rubber dam should always be used with three-step total etch cements. In my opinion, however, a poorly placed rubber dam is less effective than a proper control of the operative field. So, in selected non-standard clinical situation with or without rubber dam, it is possible to apply for isolation aids, such as partial dams, retraction cords, and Teflon tapes. They are not the gold standard, they are not the rubber dam, but they could be useful to isolate partially the operative field. And she's Louisa, a very beautiful lady who didn't like the diastema and color of her teeth and presented with very thin biotype and gummy smile. It's the nightmare of each prosthodontist. As usual, according to the principles of minimal intervention dentistry, I used the mock-up guided preparation technique under stereo microscope to keep as much enamel as possible to achieve the best adhesion and without interfering with the soft tissues due to the very thin biotype of the patient. And for the same reason, in this case, I prefer the split dam technique to be used together with other isolation aids just like the retraction cords, cotton rolls, and Teflon tapes, opening a kind of window on the cementation area since it allows for the contemporary cementation of multiple restorations without placing and removing clamps several times, with risk of iatrogenic injury of the gingivas. And here you can appreciate the 2-week recovering of the soft tissues with a good aesthetic outcome and an optimal healthy state of the gums that were carefully respected during the time-consuming cementation procedure. Differently, if you decide not to use the full rubber dam, Teflon tapes can be useful to protect the surfaces adjacent to cementation area, creating a kind of waterproof barrier. In my opinion, they can be used with simplified luting agents for the cementation of full coverage crowns with primary retention and only as isolation aids in adhesive techniques involving non-retentive restorations requiring a complete control of moisture and contaminants. And in this slide, you can see a little trick. You can fabricate very thin and gentle waterproof retraction cords, just rolling a piece of Teflon tape and insert it within the surface. You will displace the gingival tissues and preventing any contamination by the intracubicular fluid and resin remnants entanglement at the same time. Very, very gambling if you are using self-adhesive resin cements. And if you have to manage with full crowns, a valid alternative to purely adhesive techniques is represented by resin-modified glass ionomer cements, user-friendly luting agents that tolerate wet contamination can be used without strict isolation and are really versatile since are suitable with different materials, just like metal ceramics and zirconia. And hybrid cements are particularly useful in case of subgingival margins. They do not significantly interfere with aesthetics in anterior sides, just like in this re-entry case on a previous zirconia crown with an exposed margin. They offer good retention and disciplined stability in posterior areas, particularly in those cases in which the risk of cement entanglement may gamble the final outcome, as in the case of the substitution of this smaller crown, and can be used safely to cement even implant-supported restorations with both titanium and zirconia abutments. So when I have to decide what kind of isolation technique to use, I mainly consider two different clinical parameters: the gingival biotype on one side and the lip line on the other. When I have thick tissues and no aesthetic risks, I always use the full rubber then, whilst in the presence of multiple restorations and thin gingivas, I usually prefer the split them approach together with the retraction cords and Teflon tapes in order to limit possible injuries and iatrogenic recession of the soft tissues. And finally, the selection of resin-luting agents has to take into account the moisture content of the operative field. If it can be kept dry, total etch resin cements still represent the gold standard, particularly in the presence of enamel and in the anterior areas to prevent microreject and peripheral staining. Conversely, in the presence of residual humidity and onto dentin, self-adhesive cements should be considered the first choice materials. We are moving towards the end of this presentation, and I've prepared a very few slides just to sum up the clinical protocols about the cementation of all ceramic materials. So, as we have mentioned, glass ceramics, both feldspathic and lithium disilicate, have to be cemented with adhesive techniques to be strengthened, creating an adhesive monoblock and improving both the mechanical properties and longevity. Conventional cementation with low adhesion luting agents is definitely not indicated with such glassy materials. Glass ceramics have to be etched with hydrofluoric acid for 20 to 60 seconds, according to the silica content, and silanized. Then you can go for total or self-etching adhesion and resin cements, light cured in case of thin and translucent ceramics, or dual cured in the presence of opaque cores or thicker restorations. It is worth noticing that the properties and performance of dual cured cements are much better if they are light activated. So always initiate the chemical reaction with a few seconds of photopolymerization. Vice versa, zirconia is a silica-free ceramic metal oxide and should be cemented with conventional or resin-modified glass ionomer luting agents. Differently, simplified resin cements can be used in those cases in which we would like to improve a not satisfactory retentive geometry by means of a kind of active chemical adhesion. Field isolation is not mandatory, but the control of contaminants such as blood and saliva is always recommended. Zirconia has to be conditioned with both chemical and mechanical surface pretreatments, just like mild sandblasting and tribochemical silicoating. In case of simplified adhesive cementation, coupling agents just like MDP-containing primers and silane may finally improve the bond strength. And if you choose to use translucent cubic zirconia, you can go for light curing resin cements, but consider that it presents reduced translucency, and consequently, it is always advisable to use light activated dual curing resin cements. So, on the basis of the most recent literature, it is possible to draw guidelines for the cementation of dental ceramics. Well, it is for feldspathic materials that strictly necessitate adhesive techniques to be strengthened by means of the formation of a unique adhesive complex. It is as well for lithium disilicate, for which pure adhesive or simplified techniques will be used according to the type and the thickness of the restorations. However, no univocal guidelines can be drawn for zirconia, as nowadays conventional luting agents are considered the gold standard, but simplified resin cements could be useful in case of insufficient retentiveness of preparations. Thus caution, to date, zirconia cannot be considered a first choice material to cement purely adhesive restorations. And now, let's try to sum up all the information we have discussed today in a very few clinically useful conclusions. Briefly, let's see the key points to achieve the best adhesion. Preserve as much enamel as possible, mainly on the restorative margins. Carefully remove all contaminated tissues, particularly the infected dentin. Keep the proper moisture content according to the chosen bonding technique. Use the selective enamel etching with simplified or universal cements on the margins. Clean up thoroughly dental surfaces by means of surfactants and dedicated cleaning solutions. Periodically check the power and wavelength of light curing units. If choosing self-etch techniques, always use MDP-containing primers. Vigorously blow the adhesives to completely spread them over the adhesive surface, creating a very thin and homogeneous bonding layer. And finally, apply an extra coating of resin to seal any possible porosity of the adhesive interface. Now we have all the information necessary to answer the most frequently asked questions about the adhesive cementation. To date, there is no cement suitable for all clinical conditions, and it's up to the operator to select the most appropriate technique. Literature data are not exhaustive, and further clinical trials will be useful to better understand the long-term reliability of the latest generation materials. Then, how to choose the best adhesive technique for all ceramic materials? Well, for sure, not only blindfold trusting marketing advertisement, but carefully assessing the presence of silica components, the retentiveness of preparation geometry, and the conditions of the operative field. In conclusion, research has to go both in laboratories and clinically for sure. As to date, the choice of the best cement is still based on a comprehensive understanding of all the variables contributing to cementation, such as material properties, patient's needs, and expertise of the dentist. At the moment, it is clear that no material can be considered ideal for all clinical situations, and considering the constant development of innovative materials, clinicians have to stay continuously updated to choose the best cementation technique. And finally, adhesion should be considered a powerful tool, but not an irremissible prerequisite. In prosthodontics, cementation mainly means retention and not necessarily adhesion. In my opinion, good clinical practice should rely on expertise and evidence, and not on the fashion trends or single pics posted on the social networks. Then, let's look at the future with the experience coming from the tradition and the good clinical sense, with simplified techniques based on clinical and research evidences. Well, time is up, but once again, I would like to thank you all for being here today. Moreover, I would like to express all my gratitude to the Turkish Academy of Aesthetic Dentistry, and in particular to my friend, Dr. Özgürt, for this prestigious invitation. I hope my speech could be useful for your clinical and e-learning activities. And in this slide, you can find my contact. So feel free to send me a message for any further need. Let's hope that social distancing will end up as soon as possible. Otherwise, we will meet online again. Thank you very much for your kind attention, and good evening, everybody.